It's my pleasure to welcome everyone to our webinar series, At the Forefront of Mental Health. I'm Maureen O'Connor, president of Palo Alto University. At Palo Alto University, we're dedicated to addressing pressing and emerging issues through research and training in the fields of psychology and counseling. Today's discussion addresses the mental health crisis that exists today among our nation's children. We are pleased to have an expert panel of psychologists who will examine this critical issue. Moderating today's panel is Palo Alto University's own Professor Robert Friedberg. Dr. Friedberg is a licensed psychologist focusing on children, adolescents, and families. He's board certified in cognitive behavioral therapy. He's a fellow of the American Psychological Association and the Association of Behavioral and Cognitive Therapies. He's the author of 12 books and many, many scholarly articles. I'd like to welcome Dr. Friedberg, who will introduce the remaining panelists. Dr. Friedberg.
Thank you, President O'Connor, and welcome everyone. Let me just give a brief introduction and then turn to our expert panel. First, I have some good news and some bad news to share with you. Let's begin with the bad news. We are in the midst still of a pandemic that has multiple waves. And prior to the pandemic, the status of pediatric behavioral health care was alarming, and the pandemic has just made it worse. Cases are surging, and that cascade of increasing referrals and need for care is not expected to be self-limiting. We're going to be dealing with this for years and years to come. And the pandemic really laid bare two really striking problems in pediatric behavioral health care. One is the undersupply of genuinely trained practitioners who deliver evidence-based practices competently and with both fidelity and flexibility. And the second alarming issue is that the level of care within the community is very, very uneven. Now, here's the good news. I am joined by 4 expert clinicians. All 4 of these experts work in different settings with different populations in different parts of the country. The commonality is they know that good treatment matters, and they know how to deliver genuine evidence-based practices. So let me begin by just introducing you all to them. Dr. Michael Tompkins, Dr. Rosmead, Dr. Thordarson, and Dr. Paternostro. Michael, if you could just tell us a little bit about yourself, what you do, and who you serve.
Thanks, Bob. I'm in practice. I have been for many decades. I am located here in Oakland, California, and I would agree with Bob. The pediatric needs in my community have always been high, but I would say the number of referrals to my practice have increased by 20 to 30% over the course of the pandemic across the board. I provide cognitive behavioral therapy primarily for anxiety disorders, which is actually the #1 mental health issue for a pediatric population. And the good news is that cognitive behavioral therapy is the psychological treatment of choice for that particular problem. I have the privilege of actually seeing kids get better in a relatively short period of time. So it's very rewarding.
Michael, I'm just going to add a little bit. He also does training at the Beck Institute, and he is a board certified diplomat in cognitive behavior therapy.
Thank you, Bob.
We're going to go alphabetically. So Dr. Paternostro, if you will weigh in.
Thanks. Yeah. Thanks so much for inviting me to participate in this expert panel with some of my old colleagues too. So my name is Jenna Paternostro. I'm a pediatric psychologist at the University of Iowa, Stead Family Children's Hospital. I see kiddos who have a range of acute or chronic medical conditions. I also work in our multidisciplinary gender health clinic too, doing gender affirmative mental health care for kids who are transgender or identify as gender diverse in some way. I absolutely agree with the worsening mental health crisis that we're in. I am overbooked every single day, unfortunately, in trying to get the needs met from our patients who have comorbid medical conditions. I practice CBT as well, which is the gold standard for anxiety. I see a range of kids who have anxiety, health anxiety, depression, school refusal. For our kids with medical conditions, I see a lot of our kids who are struggling with adhering to their medical regimen and trying to get them the care that they need in a timely manner as well.
And Jenna, don't you do something with integrated pediatric care clinics?
Yes, I only work in pediatric subspecialty care clinics. So I work with kids who have diabetes, cystic fibrosis, any comorbid medical condition.
Great, thank you.
Yeah.
Dr. Rosmead.
Hi, everyone. My name's Erica Rozmid. I'm a clinical psychologist. And about a year ago in May 2021, I opened up my own private practice called Clarity CBT and DBT Center. I use measurement-based care, which means that when people first enter my office, I send out measures to kids and their parents, and I track their symptoms every single week to make sure they're getting better. So I specialize in anxiety and depression and suicidality. So I'm certified in cognitive behavioral therapy, and I also provide dialectical behavior therapy, which is for teens and adolescents who have self-harming or suicidal behaviors. And I just completed a training in dialectical behavior therapy for children. So that's kids 6 to 12 years old who have more aggressive behaviors. And that's a family approach in treating the entire family and the kids' problematic behaviors. And that's a little bit about me.
Great, thank you. And batting cleanup for us is the exceptional Dr. Micaela Thordarson. Dr. Thordarson, will you tell us something about what you do and where you do it?
Sure. My name is Micaela. I practice dialectical behavior therapy, so DBT, as Dr. Rosmead shared, she does as well. And I practice with Children's Health of Orange County down here in Southern California. And I practice in a level of care called IOP, or intensive outpatient. And what that means is the kids who come and get treatment from our program are receiving between 13 and 15 hours of treatment a week. So we are typically serving a group of kids who are experiencing a relatively severe level of pathology. Nearly all of our teens are experiencing some form of suicidal thoughts and behaviors and/or self-harming thoughts and behaviors. Ideally, our kids are getting to us before they end up in a mental health inpatient center. And about half of our kids do end up coming to us directly from a higher level of care, which would be an inpatient center or a residential treatment center. Our program requires participation of parents because I think if we have any parents in the audience, whether you're parents of teens or young ones, you must have that feeling that it is really hard to accurately help a young one who is not also getting additional support for their parents. So our parents are actively involved in treatment. We also use measurements to track progress and evaluate how much our program is helping our kids. And fortunately, our measurements do indicate that our program is helpful at reducing the suicidal thoughts and behaviors, as well as increasing adaptive skill use.
Thank you, everybody. In a recent article that was in JAMA last year, that globally, one in 4 youth are experiencing symptoms of depression. That depression is also often accompanied by suicidality. And the suicide rates, again, were high pre-pandemic. They are higher now. So let's start with Dr. Thordarson. Tell us a little bit about how you treat depression and suicidality and what you think is the best way to do it, what both parents and clinicians should be looking for in their depression and suicidal treatment.
quite frankly, the place I'd like to start is that suicidality is incredibly scary. In DBT, we call it a life-threatening behavior as like a term, and it does mean that a child's mental health condition has reached a life-threatening status, right? If somebody is considering ending their life, that is a scary thing. And it is very treatable. And so I think that so often, and I know, I'm sure Erica and Michael experience this all the time, is it is really hard because I'm at that higher level of care to find a regular outpatient provider who is willing to work with a kid who either currently has or has a history of suicidal ideation. And especially when the pandemic started, we had a number of providers saying, well, I won't treat that via Zoom, which I obviously have lots of feelings about. And so I think the thing is that it, to me, and obviously this is my daily experience, is that I work every day with kids who are having these thoughts and behaviors, is that while it is serious and scary, it is also very treatable and simply another symptom. And so I think that if you can really hold those two things together, that this is serious and I need to be aware, while also recognizing that if you practice an evidence-based therapy, especially one of the behaviorally based therapies, I'm obviously biased, so DBT, CBT, or ACT, right? Those treatment packages come with a host of skills that are very successful at helping kids navigate stressful situations and strong emotions. And so I think really leaning into and relying on your training and the fact that the skills that we teach our youth and their parents really do work. I think I feel more confident when I'm grounded in that training, when I'm grounded in that science. And then, you know, it's not just that we think it helps, we are seeing these reductions and lingering effects after kids discharge from treatment, that they are, you know, doing better and staying better for at least a period of time, although the pandemic is also messing with that.
What would you see as sort of maybe the two or three or handful of things that either a parent should look for in their treatment or a clinician should do?
I think the simplest answer is that it should be an active treatment. And when I say active, I mean that kids and their parents, we would hope, are learning new ways of responding to stress and strong emotions, troubleshooting those skills, and then actively practicing them outside of the however many minutes of therapy that you're getting. Because 1 hour or 50 minutes a week, even 13 hours, quite frankly, 13 hours, that's a lot of therapy that we are doing for our families a week, is not going to make a difference if the things that we're teaching our families are not being actively practiced outside of the session. That also starts inside session. So you teach something, and the moment your mouth closes on teaching something, you are practicing it, and you're doing it together, and you're practicing doing it wrong, so that you can feel the difference between what it feels like when it's not working versus when it's starting to work. And I think also my heart goes out to every other provider out there. So if we've got therapists on the call, we have been in a really challenging situation by ourselves as humans, but then also serving a population that is in desperate need, that feels like we can't do enough for. And so I think that it's also really easy to drift away from the training and to just kind of fall into the, tell me what your problem of the week is. Oh, that's really hard. I'm here for you. I'm listening to you. And it's easy to fall into that. And there's lots of literature on drift. And so I think it is invigorating and it brings more hope to a person when you are able to kind of reground in the more active teaching and sharing of these strategies, and then holding accountable for that outside of session practice.
Great, thanks. Let me now move to the outpatient private practice folks. What's your take on sort of the same question of seeing greater kids with more depression and suicidality in an outpatient basis?
I actually came from UCLA, and when I was at UCLA, I was really primarily working with youth right after they got discharged from the hospital following a suicide attempt. And my goal as a practitioner is to keep kids out of the hospital. So that's why I'm willing to see kids who have high suicidality and self-harming behaviors, because the treatment works. I always tell parents and families my job would be very depressing if I saw these kids and they didn't get better. I would not be in the field I'm in. So I'm only able to work with these kids and families because the treatment works. And as Dr. Thordarson was saying, it's really rewarding. I can see sometimes youth for 6 months. That's like the shortest amount of time. I sign them up for a 6-month course of DBT. And sometimes it can take up to a year, but there is an end in sight. And some things that I tell parents with dialectical behavior therapy, but even with CBT, is that it's a really collaborative treatment. You want to make sure that you're setting an agenda at the beginning of every session. There's homework throughout the week. And with dialectical behavior therapy, it's only an adherent program if you offer phone coaching, if the therapist is on a team with other providers. There's individual therapy, and then there's a skills component. So if you are a parent looking for therapy, those are the 4 things you want to make sure you're seeing. And it's also totally normal to interview your therapist. I mean, I encourage you to shop around, look for different therapists. This is not your typical talk therapy. It's really challenging. And I will tell people up front, this is a lot of work, but it works. And unfortunately, I've seen a really high increase in the problematic behaviors of suicide and self-harm post-pandemic. Social anxiety, reintegrating back into the world is so much harder. I have so much empathy for these kids who have been able to go behind a computer screen and now they're faced with learning how to reintegrate their lives. And OCD, with a lot of phobias around germs and COVID, it's a really fine line balance around what's normal, what's typical, what's not. And then lastly, I don't know why, but I've seen a huge increase in tic disorders as well, and Tourette's. So that's just like what I've been seeing over the past few months. But I encourage all of the parents out there to really interview your therapist before signing up.
Now, you were at UCLA and you were exposed to a brand new, an emerging approach there. Could you say a little bit about that?
So at UCLA, I really primarily worked with youth from 12 to 17-year-olds. And my boss at the time, Dr. Jonah Sarno, she developed this 2 to 5 session treatment, which incorporates CBT and family-based therapy. And it's really a way, it's like a crisis management to give these kids and families enough skills. We also developed this online tool that will be coming out soon called Lock and Protect. And it's a lethal means restriction tool. So parents can go online and basically you're asked all these questions. It's like baby proofing your home for your suicidal teen. And so there are things in your home that could be potentially dangerous for the child living in your home that you don't know about. And it's a really great way just to get thinking about how to make sure the environment is really safe. I also was working on a grant that is now being implemented across the country in many hospitals that is actually a hospital intervention that works. So if your child has to go to the hospital, they will actually get intervention in the moment and hook them up with resources that work.
Great. I'm glad you unpacked that a bit. Michael, what's your take?
As an outpatient practitioner, I agree with everything my colleagues have shared. I would say that it's not, the problem is not just a step down problem, meaning that, if you're an inpatient unit or you're an intensive outpatient unit treating youth and you're looking to step down care to an outpatient therapist, that's one set of problems. But as an outpatient therapist, stepping up is another big problem. The resources for suffering youth who require or would benefit from stepped up programs, there are too few programs, whether we're talking about inpatient programs or intensive outpatient programs. And so what this means for all of us is that it's really, given the dearth of step-up programs, it really is important that we outpatient therapists know how to treat these kind of high-risk situations on an outpatient basis. Because at the end of the day, we don't always have a lot of options in stepping up, frankly. And so that's a call out to society at large to actually dedicate resources to actually building out programs to actually help kids across the spectrum in terms of need. That's one thought. And the other thought I think is really interesting that people have shared is that I think everyone would agree that sleep is probably the most sensitive index of emotional well-being. And when we're not sleeping well, we're generally not doing well. And I have seen a huge increase in the number of youth, not just adolescents, which I would expect, but also young children who are having really difficult sleep problems. And I think it is because of the pandemic and because not just of the stress that's related to the pandemic, but I think the loss of structure, the loss of social benefits that influence our mood and our circadian rhythms, and the lack of structure within the home and outside the home have left many youth just really struggling to sleep well. And if you're not sleeping well, then everything is harder. So I think the pandemic has hit sleep big time around the youth that I see.
Really good points, Mike. I hope if there are any stakeholders out there that can help maybe allocate a little bit of the budget surplus that's supposedly in California towards mental health beds for youth, that would be a good thing. And let me move to Dr. Paternostro and just take a different edge of this. We kind of know that another thing that complicates depression, suicidality is acute and chronic medical conditions. Mm-hmm. Living with a body that doesn't work well is also another stressor. So Jenna, can you tell a little bit about how you work with kids who are depressed and have comorbid, either acute or chronic medical conditions?
Yeah, so I see patients primarily in an outpatient setting. I would consider myself probably the lowest level of care. So I see patients probably, well, it varies based on availability, but maybe once every 3 months. So that really complicates the picture and the treatment that I'm able to provide as a pediatric psychologist. I am able to see some kids more regularly, but maybe at maximum I can see kids about every 3 weeks. So generally, if I see a patient who has high suicidality, pretty severe depression, I do try to refer out. Here in Iowa, this shortage of quality mental health care is extremely limited. So I find it a hard balance to find people that I trust and that I would feel comfortable referring my patients to, and also wanting to protect my patients and do what I know is also best too, because I have the ability to treat those patients based on my training, but I don't necessarily have the capability within my schedule. So I do see, as much as I can, I will see patients who maybe have more mild levels of depression. And it does complicate it when they have a comorbid medical condition, because not only are our patients trying to navigate the pandemic and just the general stress of adolescence, also managing complex treatment regimens that at times are life and death in itself. Can be incredibly challenging. In addition, some of our kids, especially with like type 1 diabetes, they have access to lethal means on their body. So at any time, if they're feeling high stress, high suicidality, they can press a button and give themselves high doses of insulin that could kill them. And so trying to navigate that in a safe way and providing that level of care to our patients has been an ongoing challenge. Generally, if I do have a patient who is that high severity, then I do try to refer to our psychiatry department here, but they're overworked just as everyone else is. And so getting them in a timely manner is really difficult. I do a lot of family-based work to try to support the patient in their home environment and try to do short, brief interventions to help at least get them to the next stage, especially if the risk is a little bit lower. Maybe it's more passive suicidal ideation rather than active, then working on, the general like behavioral activation, trying to get them engaged in positive, meaningful activities. That's been very difficult with the pandemic in itself, and trying to get them engaged in activities that were shut down for a while. Here in Iowa, things opened up pretty quickly. So I have my own thoughts about how that has happened, but it has provided more opportunity, a more like back to normal sense here in Iowa than maybe other states that were more restrictive or had greater kind of closures. But yeah, those are some of the things that I guess I would see in my practice.
Jen, I mean, again, that's really alarming about the patients you see who can play with their blood sugars lethally. All right, let's just change to our second topic, which is the most prevalent disorder, particularly now, anxiety and anxiety spectrum disorders, right? And again, similarly in that same JAMA study, 1 in 5 kids globally are experiencing symptoms of anxiety. Michael, how do you treat those anxiety spectrum disorders? What should parents look for in the treatment of those kids? What should clinicians be doing?
That's a great question about when parents know that actually perhaps a referral to a mental health professional is in order. I usually recommend parents attend to the 4 Ds when it comes to really any emotional disorder, but definitely anxiety disorder. So the first D is disproportionate, meaning that the kid's anxious response is actually disproportionate to whatever the objective reality is. And the best measure of this for parents is to ask themselves, does Johnny's anxious response, is it similar to my daughter's anxious response, or is Johnny's anxious response an outlier to the way my other kids respond? The second D is disruptive. Actually, how disruptive are the anxiety-related symptoms? Obviously, school refusal is a very disruptive behavior that comes out of kids with undiagnosed and untreated anxiety disorders. Although school refusal is a behavior, and there are many factors that influence school refusal behavior, but anxiety is certainly one of them. The third D is distress. Do the anxiety-related symptoms actually distress the kid? Are they having panic attacks and freaking out? Are they really distressed that they're too anxious to go to bed? Are they too anxious to think about doing things with other kids? And then the last D is duration. And this is quite important because our anxious responses are completely normal in response to a stressful event. So for all of us with regard to the pandemic, I think all of us had some point where we were really quite anxious and stressed for a period of time, but we returned to baseline at some point. And usually the number is 6 months. So if the first 3 Ds are in play for longer than 6 months, then as a parent, you want to be thinking that perhaps there's something else going on here, right? In which case I would recommend you get your kid in for an evaluation with a qualified mental health professional. So yes, definitely anxiety disorders have been the number one. I think there have been a number of kids who have been with anxiety disorders, undiagnosed anxiety disorders, who have kind of been limping along. But I think the pandemic and the changes secondary to the pandemic just caused these like subclinical anxiety disorders, if you will, to become more manifest. And so I think that is one reason that we saw so many more referrals. And the last point was particularly with regard to adolescents, the prevalence of social anxiety disorders in adolescents is the highest in that particular developmental age range, something like 15 to 17 to 20% of adolescents have a social anxiety disorder. And so I think there's been, I've seen a lot more of that in my practice. Young, teenagers who have had an undiagnosed social anxiety disorder. They were kind of getting along, but then the pandemic hit, and the social isolation and avoidance that was secondary to being in a pandemic just worsened their symptoms, and they lost a lot of ground, and it just worsened. But going back to some of the points that my colleagues are raising, these problems are treatable problems. You know, no kid should suffer, needs to suffer actually today, because we have so many evidence-based, effective, and durable treatments for these conditions in youth. It's just about connecting the youth to the right resources in a timely way.
Now, Michael, I'm going to ask you a question. What are your thoughts about how important exposure is in treatment of anxiety?
Emotion exposure. I actually just read a paper about this recently where they did a study on behavioral activation, which in my view is an emotion exposure, that actually emotion exposure appears to be the central ingredient in the effectiveness of any treatment, evidence-based treatment for an emotional disorder, whether we be talking about anxiety disorders or depressive disorders. Being able to act counter to your emotional state is the path forward for us when we're suffering. And so, yeah, it's absolutely critical. And I would say, particularly in the treatment of anxiety disorders, one question for parents to ask the provider is, do they provide exposure, and what does that look like, and how do they do it? Lots of questions around exposure, because there are studies that actually show that actually people who say they do CBT and treat anxiety disorders, only a fraction of those individuals actually provide the active ingredient in the treatment of anxiety disorder, which is exposure. So it's a critical question. I really encourage parents to actually do their reading about it.
Thanks for making that point. That's also one of the things that is just frustrating for me, and I'm sure all of you, is that we know this works. Parents should ask their therapists, do they do exposure, and what does that look like? Jenna, what about you? Anxiety and what's your take on treatment of anxiety with kids with medical conditions?
Yeah, so in the work that I do, so I work with a lot of kids who are already immunocompromised, or for example, my kids with cystic fibrosis, which is an airway disease. I think I saw a lot of anxiety, especially at the beginning of the pandemic, and a lot of information coming out that kids with diabetes or asthma or cystic fibrosis, although that wasn't talked about as much at the time, they were at higher risks of greater complications from COVID, which I think changed the way that a lot of our kids and parents dealt with COVID, or at least kind of how they were making sense of it. I saw a range of parents who were, took that very seriously and did a lot of isolation and protected their kids. And then I saw a range of other parents who fought against that and wanted to get their kids back in school. So the families that were a bit more anxious about COVID and how that was impacting their medical condition, I did a variety of different strategies. I think it's hard. I absolutely agree with exposure. I do exposure with most of my kids who are anxious at some level, and trying to figure out that balance with COVID exposure was difficult. So really wanting to promote kids getting back into school without the parents and the kids' fear that prevented them and made sure, wanted them to, it led to a lot of school refusal and also just kind of avoidance in general. So trying to navigate that and talking with the healthcare team was really helpful. And a lot of our providers here actually promoted going back to school pretty early on in the pandemic, especially because a lot of their peers who maybe didn't have medical conditions were going back to school and participating in activities and seeing their friends. And so morally, I had like, oh my gosh, COVID is such a terrible thing. We need to be taking this seriously. We want you to be isolating. We want you to be quarantining. And at the same time, when you have everyone else, all of your peers going back into, their functioning, like their activities, that made it very challenging for a lot of families. So really having conversations with the providers to kind of reassure, like, okay, well, if you're taking these steps, that can maybe get you back into school, get you back into these activities, while also kind of managing that anxiety too. So that was one approach that I used probably the most in regards to getting kids kind of back into their activities and function.
Thanks, Jenna. Erica, how about you?
So I do a lot of exposure, and during the pandemic, I was trying to think of creative ways to do exposure. I always tell my kids of like, this is a true story. I have a fear of spiders and bugs. Maybe my cockroach infestation contributed to it, but I definitely should do my own exposure therapy. But I always ask my kids, what's the best way for me to overcome my fear of spiders? And they all say, you face your fears. And so that's what we do, is we face our fears to overcome them. And I invested in virtual reality headsets a few months ago because I thought it would be a really fun way to gradually expose these youth before actually facing it. Although it's a little more difficult, it makes me a little dizzy. So I'm still trying to figure out how that works. But I downloaded these videos of public speaking where a kid could put on the virtual reality goggles, see an audience of people who look really scary and are making mean eye comments. And the idea is that to overlearn during an exposure. So if you can talk in front of a room of 150 people like we are right now, then talking in a group of friends of 5 people isn't going to seem so hard. So I do a lot of exposure. And now that the pandemic and things are opening, it's a lot better. I'm even in a couple of weeks meeting one of my adolescents out on the town to go go into random restaurants and ask for job applications. And so I can coach my adolescent before and afterwards, and dealing with rejection and exposing to different emotions is what I do all the time. But social anxiety is definitely heightened now that most teens and kids had months and months and months of not needing to talk with other youth. And then one other thing is I also do selective mutism, which is an anxiety disorder where kids don't speak in public settings. So for Zoom, that's a really helpful tool, as sometimes it's hard for the kids to talk to even me in person. And so gradually exposing to talk to me, we can talk on the phone, we can do video sending back and forth. So there's so many different ways to do exposure, but that is the way that the kids and teenagers will start living a life that they want to live without avoiding the things that make them anxious.
Great examples, Erica. Thanks for that. And then kind of winding up, again, batting cleanup, Dr. Thordarson.
I think the only thing that I would like to add to what all of my esteemed colleagues have shared is the upside to telehealth. I know that being in person is ideal for so many reasons. Our brains are better stimulated by social interaction when we're quite literally, face to face. And one of the things that we were able to do in our program via telehealth was engage in what we call ecologically valid or exposures that happened where the kids needed them. And so, in doing an emotion exposure in a bathroom for a kid who's got some body image concerns or who frequently engages in self-harming behaviors in the bathroom, so that we're actually creating new learning where they need it. I had a kid with OCD who I figured out hadn't left her bedroom in months by the time I was treating her. And so our treatment involved taking her mobile device and walking to the kitchen and then back to the bedroom, and walking, out to the front door and then back. And so these were things that would have taken a lot longer if we had started the process in the clinic and then built up, because she would have been alone doing these exposures in her natural environment. And so I think that because psychologists and a lot of the mental health clinicians are licensed by state, if you aren't finding somebody local to you then I think if you can find a phenomenal provider who you can only do telehealth with, I send people to Erica all the time from Orange County. And so I think if you can find somebody who's good, telehealth doesn't have to be the problem, especially now that there are more things that are open up so they can get some of the physical activity and social stimulation in other arenas of their life. The most important piece would be finding somebody who's going to be a really solid provider.
Thanks, Micaela.
And
Looks like
one more thing to add with that. So about the, so I got licensed in a few different states just so that I could be able to see people where they don't really have a lot of evidence-based therapy. Not like, I mean, again, it's really hard to see everyone that I want to, but there's other ways that you can see providers, even if it's not in person, across state lines.
Can you get licensed in Iowa?
I'll try, maybe. That'll be my next state.
Thank you. It's pretty easy.
All right, looks like we have one question. Can you all, or any of you, speak to the issue of working with kids who are indigent or poor families and having to deal with these issues?
Yeah, I mean, this is like another really big factor. So before private practice, I worked in the Bronx, and most of the people that I saw there were through the Medicaid system. Right now I'm doing private practice and I don't accept insurance. So I am in some ways like contributing to that problem. It's a huge issue, and therapists are not getting reimbursed enough to be able to also make a living, especially in Los Angeles and California. And so it's even harder. I mean, there's really an access issue where people are not getting access to appropriate mental health services. And that's why I loved working at UCLA, because through UCLA, I saw everyone through actually Medi-Cal, and I was able to provide them with evidence-based treatment and connect them with resources that I would vet. I would call up clinics around Los Angeles, interview them on behalf of families. So at least I knew something about the clinics. It is a huge problem, and systematically we are failing a lot of people.
Let me ask another question. This is from a parent, which says, is there a database somewhere that as a parent or a potential consumer that they could access where they could identify a provider and the type of practices they implement?
I'll take that one because the short answer is no. The most honest answer is no. And the reason is because we have a marketing issue where there are databases. So there's Psychology Today. There is one through ABCT, or the Association for Behavioral and Cognitive Therapies. There's one through Behavioral Tech, which is our DBT, host. And the marketing issue is that there is a limited amount of vetting that somebody is doing what they are saying. And even those of us who are phenomenally trained sometimes fall off of our path, right? We have our own stressors. We begin to rely heavily on our own judgment rather than on our training. And so I think, and this is a core issue as to what's going on in our field. There's not enough at all, and then B, not enough people who are consistently doing the things that they're doing. And so I think you can look for things like credentials, as I'm sure you heard the credentials of my esteemed colleagues on this panel. And even that is not always the only way to access good care, or is not a guarantee that you're going to get good care. And so I think it's one of those things that is really disheartening as a parent, because it feels like you're shooting in the dark. And that, so I think the biggest thing that I'm guessing we would all recommend is persistence, is make the calls, keep calling, because people aren't calling back because they're inundated on the other end of those calls, and just stick with it until you're able to find somebody.
Next question is a great one, and it's a good one for us to end on. And I'm going to change the question just a bit. So the question initially was, how do we as clinicians improve access to mental health care? And I'm going to change it just a bit, because access is a problem. As we've all said, it's not the problem. The question is access to what? And so as we've all talked about, you have to be, the access has to be to something accountable and something that works, right? Good treatment matters, as we've all been talking about. So let me change the question from access to what ideas do you all have to make people who are, to help people who are in the community develop or deliver more accountable care?
One idea that comes to mind is what other colleagues have said, which is for parents to become well educated on what good evidence-based treatment looks like. And one of those ways would be, how are you tracking progress? I've done some teaching over the years, and one of the things that always surprises me is how few therapists ask the kids they're treating what their goals are. And so, you know, does the kid have goals? Are those goals shared by the parents? And is there some way that the therapist is tracking progress toward those goals? And the last point I would say is to parents is that if your kid's not getting better, you will know it. And if that's happening, look for someone else. And really, you know, you will know if your kid is getting better or not. It's, you know, you will know it.
Great, Michael. Erica?
Yeah, one other thing to add, which doesn't totally answer the question, but I just remembered this, is that some of us on this panel have developed some resources for families and parents. So I guess like last week, I decided maybe I'll start a YouTube channel or something. So I have one video that I made last week, and it's going through some tips and skills that can be really helpful for kids. Dr. Thordarson has also come up with this huge resource for parents that are in the DBT program, but they can also be used as a self-help resource. And Dr. Tompkins has written numerous self-help books. And so these can be starting points to figure out what are some of these evidence-based skills look like? Are your therapists implementing them? And if not, these are maybe some good pointers when you're interviewing for therapists, seeing what they're doing.
Erica, thanks for bringing that up and kind of underscoring those points. I see we are right about at time. First of all, I want to thank our panelists. I hope this has been as informative for you all watching as it has been for me hosting. It's really been a privilege to work with these people that I so highly respect.
Thank you all. It's been a
Absolutely.
pleasure. Take care.
Thanks, everybody, and thanks for all the great work that you do. And everybody out there, good treatment matters.